Thank you. So, good evening. My name is Dr. Sarah Coll. I'm an orthopaedic surgeon based in Cairns in far north Queensland. And tonight it's my great pleasure to introduce back again David Dall'Alba, who will introduce himself and is going to talk about rotator cuff pain, which is coming up on my newsfeed.
Oh.
No, I'm of an age.
Coincidence or just algorithms working?
I'm getting old.
No? Or our emails, maybe. It's everywhere.
It's everywhere.
So thanks so much, everyone, for being here and anyone that's online. So first of all, I'd like to pay my respects to the Yidinji people, which is where we are today. And I'd like to pay my respects to the past, the current, and the emerging elders. So a little bit about me, most of you probably know, but I did my EP degree 2014. I've done my master's in pain through University of Sydney. I've done a uni SA certificate in pain education, and I was involved with Pain Rev as a local pain educator. So that's kind of the quals about me. I love working with people in pain. And so I have a firm time limit tonight of 60 minutes. So stop me if you need to, because I can talk forever. So what I hope you learned tonight, or reinforce if you already know, rotator cuff pathology and what matters, what predicts outcomes, what to screen for, helpful patient education and communication, and how to recognise and deliver high-value care. Feel free to interrupt or ask questions at any point as well, because I know that I'm good at doing that normally. So I'm not going to go through what the rotator cuff is, because I'm sure you all know, but what is rotator cuff related shoulder pain? So it's essentially an umbrella term that encompasses impingement syndrome, bursitis, rotator cuff tendinopathy, and tears. And it's one of the most common reasons for shoulder pain, and it often starts as a degenerative tendinopathy. And the rotator cuff tendinopathies are the most common in the body, so we see it a fair bit. Results in pain, loss of function, impaired quality of life, and a lot of psychological stress, like most pain conditions. So the risk factors. So there's a lot that aren't modifiable. So we can't do much about this. There's just things we've got to be aware of. And then there's some that we can modify. We're not necessarily going to be thinking when someone walks in with these factors, maybe they're going to develop rotator cuff pathology, but it's just things to keep in mind as to health and well-being in general. So the things we care more about, what's the likelihood that it's actually going to progress if we do find some pathology? So about 50% progress, and it seems to be related to age, the size of the tear, how long it's been since the diagnosis, and the location. And I'll touch on the relevance of that a little bit later. So this is kind of an anatomical description of one of the main mechanisms or theories of how pathology, symptomatic or asymptomatic, irrespective, occurs. So what we're looking at here is a dotted line. That's like the underside of the rotator cuff tendons. So during abduction or elevation, there's this reduced space between the fossa and the head of the humerus, and that's where it contacts onto the underside of the tendons. So that's where most of the pathology seems to be found, and it's within the rotator crescent, and that will become a little bit more relevant later. So in essence, one of the main mechanisms seems to be doing things overhead, whether that be life or work. Another big one is age. So there's been so much related to age that it's kind of considered to be part of the normal part of aging. Prevalence, the size, the likelihood of progression, and re-tear rates after surgical repair are all related to age. And when we look at this graph here, you can see there's this steady increase in the prevalence, and this is asymptomatic. This is just rotator cuff disease in general, right? The only kind of disparity there is it's bigger in the under 20. That's 2 decades. So it's a bit of a different sample size. So is there a relationship between the progression of a tear and pain or symptoms? Yes and no. It's mixed. We don't really know, right? So what do we do about that? Should we operate on a tear because it could progress? So what the research tells us is when we do operate on it, it kind of resets it. And then that normal age-related progression just keeps happening. So it's not that we shouldn't do it, It's just, is that what that person needs and wants right now? And it essentially just won't eliminate that underlying natural progression. So what's the relationship between a tear and pain in general? So this was a study in asymptomatic people. So not very common under 50. And then you can see the light grey is asymptomatic, dark grey is symptomatic. So it's a bigger proportion of asymptomatic to symptomatic continually through the age ranges, right? And there is a lot of nuance to that, which we'll cover. What about shoulder to shoulder? So this is people that had shoulder pain in one side, and they looked at the other shoulder to see what the pathology was, right? So tendinopathies here, you can see that it's pretty similar between the teal and the purple. This one here, which is a partial thickness tear, pretty similar as well. And then when you get into the full thickness tear, so purple is symptomatic. So you can see that there's actually a shift there where it starts to be more related to the pain. So despite this, what about high-performing shoulders? So we know that there can be pathology without pain. What about, can you actually do things with pathology? So 50% of baseball players had rotator cuff pathology with no pain and full strength, and 60 elite level swimmers. So 70% of them had supraspinatus or subscap tendinopathies or tears, and 50 out of them were reporting to be pain-free, and 72% of them were actively training for the Rio Olympics. And 93% of handball players had abnormalities in their shoulder, and on average, 7 abnormalities for each of them. So there's a lot of pathology going on in these high-performing athletes. And what the data tells us is when they stop sport, it doesn't keep getting worse. If anything, it stays the same or improves, which was surprising to me. So it's less of a concern. You may have patients that go, I need to stop because it may just, I don't want to ruin my shoulder for the rest of my life. That doesn't seem to be the case. That's based on sporting data though, not overhead work, based on the papers that I read. So what imaging is related, because it seems a little bit confusing. So rotator cuff tear of increasing size, which is problematic to do because it means that we're waiting and seeing and then re-scanning, and features related to frozen shoulder. So reduced range of motion and feelings of stiffness were the main ones. So how helpful is imaging in guiding treatment? So this was a study that had 11 GP practices that were Dutch, and the patient population was 129 patients with acute unilateral shoulder pain and 18 to 65 years of age, and they had an ultrasound of the affected shoulder. If they were still symptomatic after 2 weeks, they were randomized to one of two groups. One was where they actually had access to the ultrasound, and this then determined what treatment they had. So if they had a bursitis, they had an injection. If they had a tendinopathy or a partial tear, they saw a physio. And if they had a full thickness tear, they saw a specialist. Or usual care. So they had no access to the ultrasound findings, and it was just stepwise. So analgesia, advice, and physio or injection if needed. And if it wasn't responding well, they escalated. So in terms of the outcomes, after 1 year, they found that there was no clinically significant difference in pain, disability, quality of life, or healthcare utilisation. And that's with physios, specialists, and corticosteroids. They didn't measure costs, which, based on the reduced healthcare utilisation, it wouldn't have made a huge difference anyway. So how do we do in Australia? Are there any GPs in the room? I don't think so. No, cool. So no shade against GPs, but this was just within the nation, and it was about 5 years ago. And it doesn't necessarily mean that's what's happening now, but it's the most common shoulder condition managed, and they're often the front line, as you guys would know for the physios in the room, right? It's most frequently managed with medications, 54% of the time, imaging, 43, steroid injection, 19, NSAIDs 19, and then referrals to allied health and specialists, it's 12. That's combined. So it was a bit grim, and the authors said, obviously it's not following guidance, right? The GPs that are tuning in probably aren't following this pathway. This is more of the population data, right? But it's not necessarily in line with what the evidence says. So this is Jared Powell. If you haven't seen him before, he's a physiotherapist. His special interest area is shoulder. He's done his PhD in that area. He's done amazing courses. His course is the inspiration for this topic tonight, and I'd highly recommend his courses. So he's developed a tool to help people in working out is imaging indicated or beneficial. So it's a pragmatic approach. If one of them, then you should do a scan. I'm not going to go through it, but I can email it out. But it's really good. Probably not going to be helpful for, or not necessary for us and a lot of GPs, but if you know of someone that would benefit from it, I'd recommend sharing it with them. So what's a good objective indicator of a cause of pain? So they found that tendon samples, when they did biopsies, actually show that there was increased inflammation and kind of messaging or signaling happening. Not very practical though, because we can't do biopsies in the clinic, unfortunately. So there is an objective marker, we just can't really use it, unfortunately. So what else might predict pain and function? So this was a study that had a look at 84 patients pre-operative, 39 with partial thickness, 20% were small to medium full thickness, and 41% were large to massive. So they found things that related to pain and function was fear avoidance, physical activity, negative coping, and negative mood. Now this badge is popping up because this is important. And this badge is going to keep popping up. When this badge pops up, I want you to think back to what this means. So we don't have good ways of knowing what's going to happen to people's shoulder pain or pathology, right? But this seems to suggest that we can predict what's going to happen, right? So what do physios find, right? There's no data on EPs, otherwise I'll be looking it up. And we don't do diagnostics. So physios, 1,000 adults were referred. They found that there were 4 baseline characteristics consistently associated at 6 weeks, 6 months. One of those was expectation of complete recovery from physio. So within the papers I read, it seems like that with self-efficacy outweighs disability and pain, even though they're listed there, right? Such that if they have high disability and pain, if their expectations of physiotherapy and their self-efficacy is high, it can almost negate that, makes it redundant, and higher pain self-efficacy. So big implications for GPs and specialists and even physios in being able to communicate the value of physiotherapy. They found that if their clinical exam was suggestive of like a pathological condition, it would then be inconsistently associated with the outcome. So they couldn't predict if they diagnosed a particular thing, that didn't indicate or predict what the outcome would be. And their predictions of how well they respond to treatment also didn't seem to align, which makes sense based on if they can't, if their diagnosis doesn't match as well. So the authors recommended a more formalised approach is required. Can anyone guess what was involved in the formalised approach?
Randomised controlled trial, please.
Yeah, well, this was, but I should have put the badger there.
Then 4 physios in...
Yeah, in physios assessments, yeah. So it was essentially more psychosocial and contextual factors needs to be applied, yeah. So when you see the word tear, what do you visualise? Hopefully it's not this. This is what patients often hear. When they hear tear, they think the tendon's gone. It's fully ruptured, right? Which, that's terrifying. If that's what you saw, for a surgeon it's not, because you can fix it. It's terrifying for patients. So how helpful is this assumption? So in an asymptomatic population, 10% are full thickness, varying widths, right? So that picture's a little bit misleading. 10% are partial thickness, right? Now, of that 10% that are full thickness, only 21% are actually like this, complete width, right? So that's 21% of 10%. And then of those full thickness, almost 80 are partial thickness, right? Sorry, partial width. Now that relevance will be a little bit more important later. But how relevant is that in terms of pain and symptoms? So this was a study that had a look at the distribution of symptoms based on the width of a full thickness tear. So in blue is asymptomatic. So in an abnormal tendon and like a partial thickness tear and a full thickness tear less than 2.5 centimeters, significantly like more in asymptomatic, but then it switches once it gets over 2.5 centimeters. So again, there seems to be this relationship between symptoms and when it's a bigger or a wider full thickness tear. So we've had a look at what the impact is of certain labels, right? This study had a look at the perceived need for surgery. This way is less need for surgery. That way is more need. And it was comparing it to the label that was used. Different labels like subacromial, impingement syndrome, rotator cuff related shoulder pain, shoulder sprain, bursitis. So what they found is there was a range of different levels of perceived need. And I don't need to explain this, but you guys all understand it, right? And the badger should probably pop up again, right? So there's a call to reframe our labels. This was a really great paper that looks at shoulders. It also looks at backs, and I think there was another. So it actually ironically says rotator cuff related shoulder pain isn't one of the best, right? Which surprised me. But rotator cuff tear, not recommended. Subacromial impingement, not recommended. And it recommended shoulder sprain, described as shoulder pain with some disruption to the tendons or the ligaments or muscles, or an episode of shoulder pain. That's kind of what they recommend to describe. Now, there is some nuance to that, but there was a better prognosis when they had these particular labels given to them. So there were 4 major themes from this particular paper. Patients really value a diagnosis because it validates what they're going through and it can guide treatment. We all know this. Poor diagnostic explanations and use of medical jargon is confusing and frustrating. And specific diagnostic labels were validating, but they promoted fear and a biomedical view of pain. And non-specific labels led to more positive views towards prognosis and non-invasive management, but some believe further investigations were needed. So there's a balance that we've got to juggle. So some practical strategies. Ideally replace rotator cuff tear with shoulder sprain or episode of shoulder pain. Now, if needed, so often that's not enough. We've all had the patients and are like, well, what is that? What does that actually mean? So this is where we want to help them appreciate the differences between that full versus partial thickness and full versus partial width as well. Because without context, they can interpret that as completely gone, can't have any kind of compensation or healing, and that it's totally nothing safe to do, and that they definitely need surgery. Not that they don't, but they perceive that they do purely based on the label. So this is where it can be helpful to give them more insights into that. You can draw it, or you can use pictures, whatever, or just describe it. But full tendon, full thickness versus full tendon, partial thickness. Same thing, just on the other side, right? Partial tendon, full thickness, and then partial tendon, partial thickness, right? And then the same thing on the other side. So sometimes just helping patients understand this can be helpful in terms of all of the psychosocial factors and fear and self-efficacy. So there is a missing gap in imaging reports that I've noticed from looking into this further. So what we're looking at here is the rotator cable. So in yellow, so this is the rotator cuff tendons essentially, right? This rotator cable goes from the lesser to the greater tubercle on the humerus, and it's about 2.5 times thicker than what's called the rotator crescent, which is here in blue. Now, it's more fibrous as well, and based on its structure and where it's attached, it essentially shields this blue bit from load. So when you're pulling and tugging on the tendon, it's actually going through the cable more than it's going through the crescent. Now, the commonly located rotator cuff pathology is about 13 to 17 millimeters posterior to the long head of the bicep. So it's within this stress shielded blue area. Now, about 30% of full thickness tears actually extend into that yellow bit, and only 3% of small tears, less than 10 mil, disrupt it. So there's a bit of nuance there. Have you guys seen an imaging report that's commented on whether or not it's disrupted the cable before? I've never seen it before. And it's something that seems to have a lot more to do with it. So the bigger the rotator cuff tear, the more chance it has. So that's where there's some nuance in the studies where there's big tears and little tears, and sometimes it's related and other times it's not. Where is the tear? Is kind of the question that we want to know more about. So after I've told you all that education is really helpful for shoulders, how helpful is using health literacy for the shoulder in recovery from rotator cuff repair? 65 patients were assessed pre and post surgery, and they found that low shoulder health literacy was associated with worse preoperative range of motion. No difference post-op, which surprised me, went against my bias. However, when I looked at the questionnaire, what it actually assessed was factual knowledge about shoulder function and anatomy. So then my bias went, ooh, what isn't being assessed? Anyone guess?
Pain.
Well, unfortunately, didn't say that. But confidence, expectations, fear and avoidance, pain interpretation. Oh, yeah, pain interpretation, self-efficacy, and understanding how to safely engage, which is pain. So it doesn't say those words. So does self-management education help? So we know that this is often something that we value, patients value, and insurers value, right? How does it help and does it help? 143 people with persistent rotator cuff related shoulder pain. 2 education self-management sessions with physio. And they reviewed all of these psychosocial factors, right? The thing that actually was protective was self-efficacy, none of these. So self-management education isn't actually really what addresses those things. It helps, but it doesn't address all of them. What about pain science with a physio? A good physio. 56 patients with chronic shoulder pain, randomized to a 4-week intervention. So physio, which was manual therapy and exercise, or physio plus pain neuroscience education. So significant improvements in AROM, disability, catastrophizing, kinesiophobia, and therapeutic alliance. So well done to the physios in this study. So what about the type of education as well as exercise? So 100 people with rotator cuff related shoulder pain, randomized to exercise plus biomedical education or exercise plus neuroscience, pain neuroscience education. 4 weeks. No difference in pain intensity or shoulder disability, which is sad. However, significant improvements in kinesiophobia and catastrophizing, right? Now, we know that that stuff doesn't change pain and function overnight. I don't need to explain the fear avoidance model to you guys, but they didn't follow up, which is disappointing because it would be really interesting to see the impact of that beyond 4 weeks. What about general physical activity? Now, this is where an exercise physiologist sticks their head up, right? Let's do something if we can't do anything. 42 people with a clinical diagnosis, randomized to either supervised shoulder exercise or the same thing, plus just moderate intensity walking. Improved activity, pain, night pain, shoulder function, quick dash, and rotator cuff quality of life. Just adding walking in, right? Surprising. Sorry. I actually don't know how far I'm pretty sure it was 30 minutes. There is a lot of power in just moving, motion's motion. So again, unfortunately, no long-term follow-up, which is disappointing, particularly as an EP. I'm like, oh, this is even more us, you know? So the authors actually because we know there's lots of ways exercise helps, right? And the authors know that a big way that exercise helps is actually probably psychological factors, right? They've stopped. You know how often someone hurts themselves and they just do nothing in terms of physical activity and they just retreat, right? Doing walking can even be empowering enough, like I'm doing something, right? Something's better than nothing. And there's a lot more to that that's beyond the scope of right now. So why does 3 months matter in terms of conservative rehab? We know that this stuff doesn't happen overnight, unfortunately. Otherwise, we get much better outcomes really quickly, right? So what are the predictors of likelihood of surgery, right? 452 patients, non-operatively treated, symptomatic, atraumatic, full thickness rotator cuff tears. They didn't comment on the width. Not many papers do, unfortunately. So you may not be able to read it from back there, but this line was when it met significance, this red line, right? So this one here is patient expectations. So within 6 months, the most likely thing that would predict if someone had surgery was actually their expectation of physiotherapy. After 6 months, it was workers' compensation and how physically demanding the need was for their shoulder. So that was after 6 months. So expectations seem to be really important in whether or not they undergo surgery. So can we change patient expectations? Lots of studies show that we can, right? There's a trial underway in terms of shoulder pain specifically. And these authors hypothesized that if we could change the expectations of people with physiotherapy, it would lead to about an 88% kind of success in avoiding surgery. Not that there's anything wrong with surgery, but that's just the outcome that they want. So how complex is assessing expectations? So it can be as simple as just asking them, what do they expect from the treatment, right? So how much do you expect your problem, whether it be shoulder pain or whatever it is, to improve as a result of rehab? It could be a number scale where you identify what 10 and 1 means, otherwise you're going to have trouble later when you're writing a report, or just giving descriptions of words. It can be that easy. So is there an immediate impact of education on reassurance and intentions for behaviour change? So that's what this study had a look at, over 2,000 people and online interventions, and they were randomised to one of 3 groups. One was structure-focused education, which was more anatomical and biomedical. One was best practice education, that kind of like pathology doesn't necessarily mean pain and let's start moving and be active. And one was that plus pain science education. Now, you'll see that it's 2 minutes 12, 3 minutes 52, and 5:52. So there was obviously differing lengths of time. And we all have limited time in our consultations, right? Surgeons even less than us. So they were then the rating out of 10 of their level of immediate reassurance. So of no serious condition is this one, or is causing shoulder pain, and intention to stay active. No, I can't even read that one. So the middle one, I can't actually remember what it was. The last one is intention to stay active, right? I think the reassurance might have been to do with surgery, need for surgery. So you can see the significant difference between purple, which is the structure-focused education, and the other 2. Not a huge difference between those 2, right? So best practice education and pain neuroscience education, not a big difference, right? The impact of our time, though, so best practice education was an 8.7 average clinical benefit, and best practice plus pain was 11.7. And we're talking about 1 minute 40 extra with the best practice, where there was that significant improvement in reassurance and intention. And then for pain science, it's another 2 minutes on top of that. So it's how much time do we have and how much extra benefit do we want to get? And this was immediate as well. This was in the moment. This wasn't 4 weeks later even. So the same study had a look at what the impact had on their perceived need for surgery. And what they found was a structure-focused education, increased perceived need for diagnostic imaging, injection, surgery, medication, rest, and activity modification, and reduced perceived need of exercise and low-cost self-management options. So that's where the bigger impact is. So this is what they feel they don't and do need, and that's going to have a huge flow-on effect, as opposed to the best practice plus or minus pain science, because they were similar in this. Increased need for simple management like exercise, hot and cold. So the limitations and the future directions of this, small but statistically significant immediate improvements. Unknown long-term impact on function, quality of life and pain, but we've got good data on this in neck and back pain. And it was low quality pain education. So we know that it actually has to be delivered by people that know how to deliver pain education, or it lands poorly and that they become people who, someone's tried that, it doesn't work. We know that they need to actually have learnt it, not just been told it. So we've got good data to show that when people get taught something, their pain doesn't change unless their learning or their knowledge actually changes as well. And it needs to be individualized. We know that standard scripts or infographics may not land unless you're able to navigate what that person's going through when they read and try and interpret it as well. So, and none of that was part of this. It was more of a generic prescription. So what is the best conservative approach in musculoskeletal pain in general, which is on the left? Exercise therapy, education, and psychosocial intervention. And on the right is specific to rotator cuff-related shoulder pain, and it was exercise therapy. So what about pitting them head-to-head? Surgery versus physio. 55 years of age and older, small, non-traumatic, single tendon supraspinatus. The outcomes, no significant difference at 5 years. And this was looking at physio versus acromioplasty and rotator cuff tears as well as one, and acromioplasty on its own. So no difference at 5 years. So which is better? It depends, right, on where the tear is, what the goals are in the patient, symptoms they're presenting with, and what they really need in that moment, essentially. So it's a lot more nuanced than those particular things. However, the impact of physio prior to surgery. So this was the MOON trial. So 18 to 100-year-old patients, symptomatic, atraumatic, full thickness rotator cuff tears. They got an instructional book and DVD, which again isn't individualized, but it's good. Week 1 to 6, they had on average about 8 supervised physiotherapy sessions, and they were given a home exercise program to do 3 times a week. They then got to kind of self-nominate whether or not they cured or recovered, whether they'd improved, or whether or not they were no better. And that then determined what treatment they had. So they had no further treatment if they cured. If they were improved, they kept doing physio, and no better, they could elect to have surgery. Week 6 to 12, they only had an average of 7 supervised physiotherapy sessions. Now, 10 years on, same cohort, 70% had avoided surgery, improvements were maintained, and clinically meaningful improvements in pain and patient-reported outcome measures of all of these listed here, which is essentially like shoulder function and disability and pain. So massive impact from the physiotherapy group prior to surgery. So the value of physio is it essentially can minimize the need for surgery later in the right person, which is why it's considered the frontline treatment for rotator cuff related shoulder pain. And escalation to surgery is considered after 12 weeks of high quality rehab. So what about if they go, I'm not doing surgery for whatever reason, right? What are the implications for them or the consequences? 417 people, 3 months of quality rehab, 190 patients remained symptomatic, and then they were randomized either to surgery, which was rotator cuff repair or decompression, or more rehab, which was physio and injections as needed. At 2 years, non-full thickness tears, no better. Full thickness tears, small, statistically significant benefit in pain and function, but the clinical significance was uncertain. So what level was meaningful for that person? So there is some nuance to the recommendations, right? Then it comes back more to that rotator cuff crescent and tear as well. So we can more safely delay it if it's in that rotator cuff, rotator crescent, whereas if it's in the rotator cable, more likely need to consider the need for surgery. This is something maybe you'll appreciate more. Dr. Coll, what you see, we probably don't see this as much, but this is
The cables are last to go.
the last.
The last to go. So
Yeah.
I'll back up. So it appears to tear from just posterior to the cable.
Yeah.
And then I think it goes backwards.
Yeah.
So it goes
Keeps going.
towards infraspinatus.
Yeah.
And then the last thing to go is the cable of the supraspinatus.
Yeah.
Does that
Yeah,
make sense?
which would match
So
with what they
backwards
find.
before it probably goes forward.
Yeah, and I didn't find it commenting on which way it went, but it was just that it starts in the crescent and then just progresses from there normally.
So I think what I'm saying is that they get these partial tears of the
Yeah.
width of the supraspinatus.
Yeah.
When they have a partial tear, the cable's still intact.
Yeah.
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 That's
Most of the
pretty
time.
common. Yeah.
30% of the time in large and 3% in small.
It,
Oh, and that was in full thickness.
the person that's done the cable has really had either a violent injury or very long, not long standing, but quite significant relentless trauma to their shoulders. They're heavy manual work, and then it's finally popped before to tear the cable. They're sort of later presentations, they're more trauma.
Yeah, and I mean, it starts progressing towards it as well over an extended period of time.
Starts progressing.
So the tear might have started in the crescent and it can just keep progressing to the cable as well if it wasn't identified.
Yeah, so what I'm saying is that they don't have, when I operate on, I would say the majority have still got a cable intact.
Yeah.
The type of person that comes in with the cable not intact is someone who's been a heavy manual worker and had shoulder problems for a long time.
Yeah, and it's just
It's much more trauma, or they've had much more significant
trauma at the time.
That's what
Which fits with what the data all says. Yeah. So what were the indication for surgery in the MOON trial? So this was that one that had the really good data after 10 years, right? So the indications for surgery were listed on 89 of the 105 reports. So they didn't even write what the indications were on all of them. 67 of them were failure of non-operative treatment. So that was the most common reason that they listed as we should operate. Pain, weakness or functional loss, new trauma, biceps problems, adhesive capsulitis and tear enlargement, like those things, but failure of non-operative treatment was above that. Ongoing uncertainty regarding what the indications of surgery are based on the data, which kind of may have led to this. And we need to consider specialist assessment if pain or disability remains unchanged at 3 months. However, some practical questions for GPs that I'm here and surgeons. When a patient presents after failure of non-operative treatment, what expectation or explanation was given? Like, what were they thinking would happen? Was there adequate structured and adhered to trial of activity? Was the program individualized? Was safe movement and meaningful activity encouraged or feared? Was self-efficacy and barriers to engagement addressed? Was work, sleep, distress, and other contextual factors considered? Was pain, function, strength, and patient goals measured over time? And in surgery being considered because function remains unacceptable despite high value care, or was it primarily because of the scan, which is kind of what that 10-year trial found? So those are questions for GPs to consider with their patients and the physios or EPs or orthos or chiros, whatever they're working with. So considerations in surgery, appropriate for selected patients. Many tears respond well to non-operative care. Some tears enlarge over time, and decisions should consider all of these things. So some presentations definitely warrant early surgical opinion, right? And that's more your wheelhouse, Dr. Coll. So the risks of low value care and the absence of pre-operative psychosocial screening, right? So they found that the impact of psychological function on surgical outcomes was correlated with high level disability and function, reduced function, persistence of post-operative pain intensity, and patient-reported outcome measures. So psychological function was related to all of these things. And that's why they recommended for behaviour and psychological management prior to surgery to address all of these things. So it's not just conservative, pre-surgical as well. Whether or not it would make a difference if they had that conservatively before they get to the preoperative stage, I'm not sure. It may make it redundant. Who knows? But there is a trend emerging. So when I was looking through the papers, there's a lot. So these were all within the last 3 years, except for one, which was like 6. So it's seemingly more recognition at the moment in the literature. And it's all related to those factors: kinesiophobia, catastrophizing, distress, all of those psychosocial contextual factors. So modifiable preoperative prognostic factors for rotator cuff repair. So this is what they had to look at, comparing it to the domains of recovery that aren't showing up, that were like function, pain, disability, quality of life. And the things that they found that predicted it was expectations for symptom reduction, which we kind of have seen before in conservative care, negative beliefs about rotator cuff tears, neuropathic pain component, sleep quality, and the neuropathic pain component was not based on identifiable pathology of the nerve. It was based on a central sensitization inventory. So basically neuropathic pain features. And sleep quality and sleep efficiency, and now they show up. Emotional functioning and quality of life. So these were all related to this and contributed to that, not pathology. So we know sleep screening is really important. If we have bad sleep, more pain, more sensitivity in the entire system affects conservative care. It then affects pre-surgical rehab or prehab. It then affects post-surgical outcomes, right? So we need to interrupt that cycle. For frontline treatment for sleep disorders, screen for sleep apnea. If they've got sleep apnea, give them a CPAP or whatever they need, and it'll have a big impact. If they don't have sleep apnea, then they need to be screened for insomnia. If they've got insomnia, CBTI, which is cognitive behavioral therapy for insomnia, should be recommended for everybody. So the last few courses I've done in the last 12 months that we always talk about: diet, sleep, and movement. It's now moving towards sleep's even more important than those because you can address it easily, quickly. Pain and stress you can't change them, but the ways they address it in CBTI can start to have meaningful impacts in sleep hygiene and their sleep practices. So it's something that's under-recognised at the moment. So this was an interesting study that had a look at what the pre-operative contributing factors were to CRPS-like symptoms after a post-rotator cuff repair. So the disclaimer is it was Japanese, so I couldn't read the paper, so I'm going off the abstract. But 312 patients underwent this repair, and they reviewed pre-operative pain, range of motion, their kind of disability index, central sensitization inventory, gender and age. The only thing that was predictive of whether or not they got CRPS was central sensitization inventory. So are they presenting with these features before? And if they are, they're more likely to get it later. So we really need to address that prior. So this was a study that looked at the contributing factors to frozen shoulder post-rotator cuff repair. 77 patients underwent the repair. They reviewed pre-op and 6 months post. They looked at the constant score, the anxiety and depression and kinesiophobia. And at 6 months, in purple is frozen shoulder, teal is flexible shoulder, right? So anxiety, significantly more, female, gender and occupational disease. So these were significantly related to frozen shoulder. So if you've got patients that are pre-operative or conservative care and they've got a lot of anxiety and depression and kinesiophobia, they are more likely to get, based on this data, frozen shoulder after they have surgery. And this was defined by that particular criteria. So some tools that we can identify these risk factors are all, you're probably familiar with all of these, so I won't read them. But the OMPSQ short form looks at a bit of all of them except for central sensitization. So it's a good way to get a bit of an idea. And then if things pop up in it, you can go deeper with more, because this is pretty burdensome to say, hey, here's your 30-minute appointment, spend 40 filling these questionnaires in, right? And it doesn't take 40, but that's what patients say, right? So you can start with something that's more brief but broad, and then go deeper if you need to. Or we've got pretty good tech these days. It can be a form that gets sent out via online or whatnot. Now, it's kind of not really optional anymore, because in WorkCover, then now every single person that has a claim starts gets the OMPSQ done. So even if low value care was being done and that wasn't being done by allied health professionals or GPs that are the first line of care, it's being done now at WorkCover. Unfortunately, the claim doesn't start straight away. So they may have seen a physio 6 weeks earlier before the claim actually starts, and they're only then getting this screening form done. And then we know things don't happen quickly in WorkCover. So there's still going to be a delay to that, but it's more for them in terms of their budgets and that type of thing. So in terms of low value preoperative care, using threatening structural language without appropriate context, and lots of others. And the biggest one is labeling care that's failed non-operative care when you don't actually know what was involved in the care. So if somebody's been doing physio for 6 months, 12 months, and it's going, well, physio doesn't work then. It's like, well, hang on a minute. What was the physiotherapy that was being done? And I say physio, but that's just where the data is, because physios do the most of this stuff in shoulder and acute. So high value preoperative care, all of these things, which you probably all know, but allow up to 12 weeks where appropriate to deliver and evaluate non-surgical care. So are they responding to treatment? If they're not, what else do we need to? Because you don't need to necessarily do that battery straight away, right? But if suddenly people aren't responding like you'd expect they would, within a week or 2 or 3, maybe we need to look at other factors in those prognostic tools. And that could be allied health, that could be specialists, that could be GPs. So we know that post-operative care is the next phase of recovery. We know that it's to build strength and load tolerance and functional capacity. What doesn't seem to be known very well is that it's influenced by all of these factors, like sleep, beliefs and expectations, appropriate loading, pain interpretation and coping, work and sporting demands, and relevant medical and psychosocial factors. These are under-recognised, maybe not loading, but sometimes. Pain-informed care may reduce catastrophizing, fear and movement avoidance. And this was a study that had a look at pain education after a rotator cuff repair. So 36 people with a small to medium, and they were randomized to 6 weeks of post-operative rehab. So they had guideline concordant physio, or the same thing plus pain neuroscience education. And it was 3 years experience. And I couldn't tell from the paper whether that was 3 years experience physio, therapy in general, or 3 years experience of pain neuroscience education, which is pretty important. So there was no effect in pain or disability. And there was a large effect size on anxiety, catastrophizing, depression, and kinesiophobia. So seemed to work really well compared to no pain neuroscience education. Again, no long-term follow-up beyond 6 weeks, which is disappointing because it'd be interesting to see what the outcomes would be. Which is why it's now recommended for anyone post-rotator cuff repair to have pain education done because of all those factors. So these are all the things in terms of high-value post-operative care. And there's a lot here. I'm not going to read it all out, but I can email it out if anyone's interested. But respect repair-specific precautions, naturally. And then protect the repair, but restore capacity, confidence, and participation, which kind of encompasses a lot of those things up above and in the middle. So red arrow is low-value care. So pain and symptoms, low-value care, more likely to lead to surgery, right? Ongoing symptoms, if there's low-value care, right? They have a good surgery done well and they have high-value care, they're less likely to keep going. Then maybe they see physio or maybe EP or some other health professional and they keep getting symptoms, then maybe they have another repair because it's just low-value allied health all the way around. Or we introduce some high-value care and maybe they recover here. Not all of them, but some of them. Or maybe if that's missed, maybe we introduce it here. And then those people recover rather than going around the cycle again. And how confident are we that if somebody had low value care from their physio or their OT or their AP, everyone's in the same bus? How confident are we that post-operatively, they're then going to start getting high value care from that same health professional? Not confident, right? So that's where it's a tough kind of consideration, but potentially we need to communicate with this physio, EP, whatever they are, and share some information about what might help, or maybe consider a different health professional. So this was a study that had a look at what influences positive experiences in rotator cuff tear treatment. So they found it was related to effective pain management or relief, so the appropriate kind of analgesia and that type of thing, informed of what to expect, confidence instilled in them from health professionals, so it comes back to their expectations, the expertise of the clinician and therapeutic alliance, and then what influenced negative experiences. So this was an interesting kind of qualitative review. So the first one is inappropriate pain relief. So the GP said, we stick to what we know, we prescribe lots. That's one quote they picked out, but it's, the data we have from 6 years ago seems to suggest that's pretty accurate. The next one was inadequate exercise prescription. So the patients are describing, it hurts too much, they don't understand, I can't do this doesn't work. The physios are saying they're just not doing it, they're scared of harming themselves, this isn't working. And there's a gap there in the skills to be able to make it work despite that, or do the right intervention, whether or not it's not movement or exercise yet. And uncertainty in their pathway. So this was surgeons saying there's a lot of work to do with GPs about ordering of MRIs and interpreting the MRIs as well. So the recommendations for positive experiences is improved education for healthcare professionals, better clinical practice guidelines, standardising care for patients with large to massive rotator cuff tears. So there is not really much in guidelines for that online. I couldn't find anything really. And the common recommendations across rotator cuff clinical practice guidelines, exercise is universally recommended. I promise that's not because of bias. Paracetamol and NSAIDs may be used, so giving them pain relief where they need it to interrupt that cycle. Corticosteroids may be used. PRP is not recommended as a first line. And return to work strategies, so making sure it's early intervention, multidisciplinary approach, and adaptation of work organisation. So this is what I mentioned before about work cover and that screening form. This is all coming about because they recognise this, and they take ages to recognise this, right? So it's exciting that they now have, but How long is it going to take them to work out what they actually need to do once it's happened? And they didn't know the answer to that when I asked them what they're actually going to do when they get these numbers, other than work out that maybe they get a bigger budget for it. So we want to be able to get that intervention as early as possible and have the screening form before work come and do it. And that might be GPs or physios. Physios are often seen even before the GP or vice versa. So in terms of conservative care, specifically for return to work, so it's all pretty much the same stuff. And we just want to escalate according to presentation. So we may need a surgical input as well. Huge gap that was identified by these authors. Impaired psychological status affects pain, function, and quality of life, which is why they recommend it. That psychological impairment largely affects rotator cuff patient condition and treatment outcomes, which underlines the importance of a multidisciplinary biopsychosocial intervention to achieve better results. So if they have access within a certain funding scheme or however they're funded to see multidisciplinary team, that is best practice to get them to get better outcomes. In terms of preventing pain chronification, early intervention, we want to do it within days to weeks, as soon as possible. Adequate analgesia, it may need to be multimodal so we can avoid all of the more harmful medications. Consider psychosocial factors and interventions, multimodal team, and psychologically informed and pain informed. Fortunately, this is our shameless plug. We have that right here in Cairns. So we have EPs, physios, OTs and psychs who are pain informed, psychologically informed, and tick all of those boxes on that last page. We don't have nutrition or dietitians though. I've done further training in nutrition specific for pain, but I don't work in the nutrition that's individualized for people based on other health conditions per se. So we all use a biopsychosocial approach. We're psychologically informed. So I've done further training in acceptance and commitment therapy and cognitive behavioral therapy, because when I started working with people in pain, 7 years ago, I started realizing I need a lot more to actually help these people because of all of these things that they were presenting with. So our team are trained in this, the EPs, physios, OTs and psychs. Contemporary pain science informed, we've all done a lot of upskilling in the latest in pain science. And one of the biggest things about pain education is it's learning how to actually translate it. So clinicians often know what the pain science is, and then when they try to deliver it to patients, it can fall short. And then if that happens, and it happens with patients of mine, hopefully less often than more often. A lot when I first learned it, because I wasn't very good at actually translating that information, is then they've had that treatment, and then it's in the basket of that doesn't work. So then if they see someone that's better at it that then tries, it's too late. That's something that doesn't work. I've tried that. So it's something to keep in mind when talking to people about it, how confident and comfortable you are with having those conversations. And there's lots of amazing courses that you can upskill in this to be more comfortable with that. We're all trauma-informed, person-centered, evidence-based, empowering, and holistic. We also, another shameless plug, have an interdisciplinary group pain program. So 5 weeks, twice weekly, Tuesday and Thursdays, 46 hours of content, pain science education. So they're learning it, and then we use movement sessions and other sessions to help them practically apply the skills that they learn. It involves movements like Pilates-based mat work, exercise in the pool, and functional movements within the gym that's aligned with what they need to get back to life, occupations like work and looking after kids and whatnot. And it involves some virtual reality. New program starts every 8 weeks in case you have someone that's struggling. And we do it via teleconferencing. And we've actually had amazing outcomes with telehealth, which is exciting. One of the most recent participants who graduated through telehealth, he was traveling in New South Wales, I think. Such a good outcome that he asked for a job and wants to help more people in pain. And now he's been put on a pain ramp to try and find a job there. So he's crushing it, and that was via telehealth. So the final take-home messages. Scans are useful, but they're one part. Rotator cuff pathology can exist without pain, which most of us already knew. Low-value care can create fear, reduce confidence, lower expectations, and build surgical momentum. Low expectations of physiotherapy are a major predictor. of early progression of surgery. And that would apply to OT and EP as well. There's just not research done on it. Screen for psychosocial factors such as coping skills and pain literacy as well. We don't have to screen as much for shoulder health literacy, apparently, according to that study. And screen for sleep and physical activity levels as well. Get them doing moderate walking if they can. Low-hanging fruit. High-value care before surgery may reduce avoidable surgery. High-value care after surgery may improve recovery. And surgery remains important for the right person at the right time. And has this person had high-value, pain-informed, psychologically informed, function-based care for long enough? Right? Any questions? Yes.
So we can stop the, just let me know when we hit 6:30, stop the Facebook. But I was reflecting on surgery and I think that one of the issues in private practice is you have to take all comers, people who come through the door. There's an expectation, as you say, by the time they get to my front door, there is an expectation that I'm going to wave a magic wand and make it all better.
Yeah.
So if you take out the work cover patients and you focus in on the private patients, the reason why I'm focusing on them is because they are self-determined. They're self-determined, right? So work cover are so disempowered, they don't know what they want to do, and I struggle a bit with the ethics of that cohort because they lose their autonomy over their whole body. But in a private practice patient, I try and keep the decision back with the patient. But I was thinking as you were going, there is a definite repair whereby we get to the end of the operation and we're kind of all high-fiving. Now, I know that's very ortho-bro.
That's good insights.
And I was trying to think about which patient that was. And there is a particular tear that it's really good. And that tear doesn't involve the biceps tendon. It is just supraspinatus. And so anatomically, there is a good tear, right? Any other tear, your results aren't ever going to match what you're describing, which you probably can get from physiotherapy, right? So the high five tear is, the tendon's not too old. It's less than 12 months. I think patients have no idea when they tore their tendon. And I'm not saying, there's sometimes they come in with it popped, but I can see if there's a stump remaining.
Yeah.
Right? So if I see a stump, then I know it's a recent tear. The majority of patients in our area, there's no stump, which means that this tear has actually been bothering them for a lot longer. They fall off things and they think that caused their tear. And I'm not convinced that they're actually related. And it's quite hard to see that. Sometimes you can see the stump on the MRI scan, but it's incredibly rare to actually get that level of differentiation.
Yeah.
So the tear needs to be within ideally within 6 months. But 12 months I can still do the high five. Right? So I know I've got a good solid repair. Even if they get a bit stiff after the surgery, this person is going to go on and have a really happy shoulder, right? With surgery. So the reason why I'm saying that is because there's a huge number of people who are not going to be happy with surgery because they don't have that anatomical care, right? Yeah. So once they start getting into massive territory, I'm very keen to pull away and, say, look, I think you might need to wait for your reverse, which is code for back to the physio. I have a lot of other ways of saying go to the physio, right? Because they're not all, by the time they see me, they're often prepped for surgical intervention. So massive tears, there's lots of different surgical techniques. We can do onlays, we can do augments and things like that. But I don't think that the technology's there to help that cohort. So I'm not saying that physio is a non-surgical option. Yeah. I'm just saying what the surgical option is really good at is potentially this group. Yeah. Right? So time, size of the tear, the number one most important, then the third one, which I had the conversation this week, is whether or not you're going to survive the anaesthetic. And this patient said, I won't survive an anaesthetic, don't be ridiculous. Right? So that's not resolving. It was fine to talk to him about the technique and I can explain what the operation's like, but it's not appropriate to have a conversation with someone who's going to die of the operation
Yeah.
right? So that's another cohort that's not really addressed. And then the other things that I look at is whether or not they smoke.
Yeah.
You know, if you've got private health insurance and you're smoking, which is not a common combination, but I've checked the data and I can't find if there's a significant difference. Then it's not, they should stop, and they need to stop today and maybe come back in a month, right? And then if their pain is still there, they can have an operation once they stop smoking, right? Because it may go away, you know, and they can do all the other things in the meantime. And the diabetics will get frozen.
Yeah.
So I have to have that conversation. Are you prepared to go through a frozen shoulder in order to get this recovery, right? So some patients say to me, why are you trying to talk me out of this operation? And I'm like, no, you're talking me into this operation. I need 100% commitment. I need you to wear that slip for 6 weeks.
Yeah.
And if you're not committed to this process, like you say, if you are not committed to physiotherapy, don't come. Right? Yeah. Do you see what I mean?
Yeah. And I mean, the expectations they have of you are being set by the GPs because the GPs.
It's prompt. Yeah.
Yeah, and the GPs are setting the expectation because they're going, oh, they've failed non-operative treatment. So
well, that's
the
the
only
exam
option.
answer, and I'll talk to that once we're off. But
Yeah.
So I don't operate on people who are already frozen.
Yeah.
So that it's not indicated.
Yeah.
And then I'm also trying to feel if they're agitated and distressed about this. You know, you talk about the pain, they're giving you pain signs. And if they come in hot and they're like really revved up, then I sort of, you know, how about we have another consultation in a month.
Yeah.
You know, like a month's a long time when you're agitated.
Yeah.
If you're really revved up and Dr. Coll won't operate, you know, what's wrong?
Yeah.
Right? So I put that air gap in there. I'll see you in a month. Maybe have another MRI, you know, like an MRI scan, see you in a month. See, I can do an MRI scan, see you next week if I want to. But do you see what I mean? I'm putting in some of those air gaps. So you know, all those things. When they're in the upper wires, old dog. But you know, because I've been doing it so long. But all of those things that you talk about, they have to be part of your everyday practice. You know, you have to be addressing all of those things that you're describing. Because if you don't address them the way you're describing, got lots of unhappy customers.
Yeah,
and they should have been.
Yeah, and I mean that month gap where they get an MRI could also be maybe talk to somebody that.
Well, that's what I'm trying to get.
Yeah.
Try and funnel them back.
And it can be tricky in the time you have to help them appreciate that maybe a psychologist or a mental health endorsed OT is what they need. However, if they see a physio,
we'll work that out as well.
Yeah, and they might get a bit more time to have that conversation as well. And you can. It's just
they don't like it when I say that.
It's hard. As opposed to if you refer to a psych-informed physio, OT or EP, then it's like, oh, they don't even know that we're addressing those things.
Yeah,
we're not doing psychotherapy for depression or stress or anxiety, with the caveat being we're addressing anxiety related to movement or injury and that. And so they're inadvertently, kind of accidentally getting mental health care with something that aligns with their expectations. And that's not necessarily what they expect when they walk in. And that's then on us as EPs and physios and OTs to determine those expectations and make sure that we can guide the conversation so that we do meet their expectations whilst giving them what you would refer them for. And you could make that clear in the referral of, this is what I really want you to work on.
I can't say it, see, so I've got to be careful what I say.
Yeah, but I mean, if you mention those factors, if you mention those psychosocial factors, that is all we need to understand. And I mean, we'll do our own assessment and work.
Pre-op shoulder consult's my longest consult.
Yeah.
I can push out 45 minutes easily.
Yeah.
Because I need to do all this.
Yeah.
I need to do all that sort of stuff.
Which is huge that you're doing that because so many people aren't doing that, which is amazing.
Yeah, but then you don't want your waiting room full of people who are miserable because they've had an operation.
Yeah.
That's what you're doing for me.
Yeah.
Right? So, you know, I'm talking about the surgery physio paradigm and I'm making a bit of a joke about it, but you're helping me avoid the miserable waiting room. You know, that's fantastic, right? That's the best gift, right? To everyone, not just the surgeon. It's not just about me.
Yeah. That's the person, the physio, the GP, everyone's like, oh my God, I got better. And all of you helped me get there.
Yeah.
it's a big impact when the whole team understand what's needed. Yeah.
Thank you. That was very good.
My pleasure.
Switch off all the recording and I'll ask my other questions.